This tutorial is designed to assist you in being able to document the appropriate documentation for discharging a patient from inpatient status from the hospital. Obviously, on an inpatient status, there are multiple documentation necessities, which include meaningful use, discharge follow-up instructions, and the appropriate med reconciliation for the patient. So this process will be highlighted and reviewed from the standpoint of discharging a patient from the critical care unit to an extended care facility. To begin the process, the provider will go to their rounds list or My Patients and identify the patient. In this situation, CCU bed 12 is the patient that we will be discharging today, and we will be discharging them to a tertiary care center. So in that process, we begin by opening the patient's chart, and it's important to understand that the discharge process for all inpatients begins under the appropriate document. Coming over here to the right on the tabs, you'll notice down here Document and Discharge Plan. This is the first teaching point. All inpatients will be discharged utilizing the appropriate specialty-specific document. In this case, the CCU Discharge Summary. Providers should not be using Discharge Plan to discharge inpatients. This tab is reserved and utilized for patients that are same-day surgery or outpatient. So let's begin the process. Clicking on Document, this patient from the CCU, I will choose the Critical Care Discharge Summary. In opening the discharge document, I need to indicate the date of service, and I need to indicate the time of service. It's the only thing that I need to document on this specific tab. Moving to discharge, you will notice that the patient's ICD-10 codes will automatically populate, which have been documented on throughout the hospital course. Providers are encouraged at this point to review the diagnosis, update them appropriately. In this situation, abdominal pain, and it has resolved, and answering the specific qualifiers, descriptions, and who the diagnosis was discussed with. After working through these, as these will be displayed on the output of the discharge summary as the actual discharge diagnoses, the provider then needs to move to the next important field, which is the hospital course. You can see this here by opening it up, is a free text field. It is here that the narrative can be entered regarding the patient's hospital course with its particular details. Having done that, we then move to the Plan tab. The Plan tab is a very important tab. In fact, this is the hub for all of the specialty-specific templates and the discharge process. It is here where meaningful use, med reconciliation, appropriate follow-up appointments, answering and adding any specific comments or instructions, and also the necessity of tobacco screening for patients who are active tobacco users, which is required. So let's begin the process here. You'll notice the discharge date flows in automatically, and already there's been some queries that have been crossed already that I have answered previously, and that is the patient wears oxygen at all times, the diet I've said can advance to your usual, and I'm saying at this point the patient is bedbound. I've already taken the liberty of entering in the patient's cognitive capacity, which is a free text field indicating near baseline, and then reviewing the smoking status. In the event that this patient is a smoker and on admission was screened as being an active smoker, patients are offered the ability for smoking cessation to meet with respiratory therapy. If an active smoker refuses or declines any smoking cessation counsel, then by recommendation and requirement that this patient be asked once again at the time of discharge if they may be interested in any smoking cessation or counsel therein. Having addressed that, the next step, which is a major function in the discharge process, is the med reconciliation. You'll notice here, this is where the med reconciliation will be performed by opening this up, and the whole process here is to review the patient's visit medications and compare them to the patient's home medications, and providing an accurate list at the time of discharge to the receiving provider as to what the patient is actually taking. Now, being discharged from the critical care unit, this can be somewhat difficult to provide and update this list. The variables and factors that are involved here certainly are, number one, that if the patient's home medication list was never placed into the system, it's difficult to reconcile the list. Hopefully, at the point of discharge is not the first time that this patient's home medications are being reviewed or entered into the systems, but sometimes that can occur. In this scenario, the patient's home medications have been entered appropriately at the time of admission. Having admitted those, placed those in the system rather, you'll notice that when I entered the med reconciliation routine, the first thing that comes up is the patient's home medication list. I'm able to review this, and then now to compare them to the visit, I want to click Convert here at the bottom. You'll notice on the footer, by clicking Convert, what is now presented to me is the patient's visit medications and home medications. Remember, the goal of reconciliation is to compare what the patient was taking at home prior to admission, what's changed during the hospital course, or new medications added. Now, what will they go home on, and what should they take? So let's begin the process. One thing I'd like to point out initially is that since this patient's medications and home medications were entered appropriately and then continued or reviewed, you'll notice it's made the setup quite nice. Looking here, you'll see that there is particularly carvedilol. You'll see it twice. The indication here is with this little house icon, this patient was taking it at home, 6.25 milligrams twice daily. Well, at the time of admission, it was suggested that they continue taking that, and that's why this link is telling us that this patient was on this medicine at home and they were taking it during the hospital course. Now the provider needs to decide what is to be done with the home medication. So by going to the home medication, I need to decide at this point, do I want to discontinue it? Do I want to resume it? Or do I want to resume it and give the patient a prescription for this medication? Let's assume that the patient has this medication at home and I want them to continue it, so I click Resume. You'll notice what happened immediately above that is the visit carvedilol, no home Rx. So I have reconciled this medication from home and with the visit. Working my way through the remainder of the visit meds and home meds, I'm able to do this process. Now, if you look at the next medication, Plavix, in this scenario, let's say that I would like to continue their Plavix at home, and again, you see, no home Rx required. But let's say that the patient asked me to provide them with a prescription. I could certainly say, well, I want you to keep taking Plavix, and I'd be happy to give you a prescription as you need this to take at home. The next medication, Colace, you'll see there is no link and there is no house icon. Same with the levothyroxine and the morphine. This tells me that these medications were initiated in the hospital stay, the acute setting, and now I need to determine what to do with them. Well, the morphine, nothing. It's grayed out. They're not going home with IV morphine. Now, the levothyroxine is a new medication. So I'm going to be new home Rx, as I want them to take that prescription and begin that and continue it at home. The Colace, at this point, I don't feel that's necessary. It was one of my PRN medications or scheduled medications during the hospital stay, and I would say no home Rx. Again, I'm working my way through this medication list, reconciling each. Again, the morphine, there's nothing that I need to do. It's grayed out, as the patient will not be taking IV morphine at home. But I come to my Carafate next. And let's say I want to discontinue this. I discontinue this because it was deemed that the patient no longer needed to take this medication. Doctor's order. Having finished the visit medications, I am now left with some remainder home medications which were not utilized during the hospital stay. I do need to address each of these as well. So let's say at this point the azithromycin is not needed anymore, as there's no active infection going on. The omeprazole, they could continue at home. And the oxycodone, they only had one tablet. They took that and there is no need for any additional pain medication. I'm going to discontinue that. Now, one other important feature to note here at this time is if you need to add a medication which is not actively here at the last minute. For example, let's say that we need to add lisinopril 5 milligrams daily to this med reconciliation. I can click on any order down here, and you'll recognize now this is the ordering routine. I can simply look up the medication that I want. In this situation, it is lisinopril. Choosing the 5 milligram tablet, choosing the appropriate string, and do not forget, these are modifiable. Anywhere I see a hand, I can change and have a click functionality change. For example, I have default 30 tabs, but let's say I only want to give them a 2-week supply. By clicking on it, I can change that to 2-week supply. Or I only wanted to say, in particular for antibiotics, let's say, I can change that to a number of days by clicking on quantity or days, and now it's 14 days. This is a very nice feature, and it allows me to edit and change prescriptions on the fly. I'll give them 14 tabs. Having completed that, I say OK, and you'll notice what happens with the lisinopril. The lisinopril now falls under a home icon and now becomes one of the home medications. One other thing I would like to mention is that you are able to edit these medications as well from this field. You can do so by simply clicking on the actual edit button, changing the milligram strength, and you'll notice what I've done is I've changed the Plavix to 300 milligrams daily, and it will be resume and with an RX. One other note, if for example you wish to have a patient hold a medication for a period of time and then resume at a later date, it would be here under the edit, and you could certainly put here under label instructions any instructions that you may want to specifically give. So you have the option to modify, add, or annotate a prescription. But remember, the goal is always to reconcile home medications against visit medications. Having now completed my entire med reconciliation process, I can move to the next field. This obviously is going to add some warnings and checks. The patient is on these medications. Typically, because they're already on it actively, it is checking against. If you feel appropriate for that to override, indicate the appropriate reason. When I submit, having now completed this, I enter my PIN as I've completed my med rec, and immediately you'll notice anything that I have adjusted for a prescription is now presented to me. It is here that I am able to print out prescriptions on specific prescription paper, which will need to be printed out and signed by the provider to be placed on the chart or given to the patient. You'll notice that the Plavix I changed to 300 milligrams daily from 75, and you see my note, do not resume until seen by cardiology. I gave them 30 tablets, and you'll notice here that these different columns. There is the ability to e-prescribe. This first column, it is grayed out. Part of that is because there's no patient pharmacy that's been identified, so it's not available. But typically these will be printed out. By clicking on the second column, the printer icon, you can see right here, clicking on each, this will print out prescriptions. Remember my lisinopril, I gave them 14 tablets. That was a new medication. The Synthroid was started during the hospital course. This is a new prescription. After checking the appropriate print column, I now will click Transmit Print down here on the bottom. And I'm presently set for preview, but you should have it defaulted to print. And if I clicked print, you'll see the CCU printer is designated. By clicking OK, those prescriptions will print out. You will need to sign those prescriptions, place on the chart to be given to the patient. In this scenario, I'm not going to print these. I'm going to cancel. And this brings me back to my discharge routine. Having done the med reconciliation, if there's any miscellaneous home medications, you can indicate them here. Primary care providers, if they've been entered into the system, will automatically default in. You'll notice this little subdued clipboard and clock. By clicking on this, you can certainly put in instructions as to when you want them to follow up. Moving then to forms, the next field. The forms field is utilized for our transition of care document. This is also a required document for all patients inpatient being discharged. Clicking on the field, don't get too confused or overwhelmed by this, but come over to Lookup. And under Lookup, you'll see these are the standard present templates that we're using. For discharge, the thing to be printed is the transition of care document right here. By clicking on the transition of care document, which is required for all discharges, and this is the information that is given to the patient or family member, indicating and reviewing their hospital stay with pertinent information. Remember, this form should be filled out using simple and easy to understand language, avoiding medical jargon. This is the form and the transition of care. The discharge diagnoses can be typed in. The reason for hospitalization, again, in very easy to understand terms that the provider and patient can understand, avoiding medical jargon. The next is asking, are there any studies pending at discharge? This is a yes/no query. If you indicate yes, then the next obvious is, what studies are pending? Perhaps there are cultures that have been performed, pathology reports, or other tests that need to be followed up on that are pending. In this situation, let's say that the patient had an echocardiogram, and the results are still pending the official interpretation. At this point, you need to indicate what is to be done with those results and how they can follow up. As far as any major procedures tests done, again, if the answer is yes, then to indicate what those tests were. In this situation, perhaps the patient had a cardiac catheterization. Again, this is what the patient will be reviewing and will have in hand at discharge. Defaulting in is the contact number if the patient or family has questions to call back. Having completed this, clicking OK, we move then to instructions. The instructions here are instructions that are based on specific disease processes. In this situation, the patient, let's say as we've been working a COPD exacerbation, I could do lookup by typing in the particular field. I do have access to some some patient education based on their diagnosis. There's a variety of options that can be used. In this situation, I'm going to pick COPD. And this is additional instructions that will be printed out by nursing to provide to the patient. If you have any other additional instructions, this is a free text. The care plan goals at this point do not need to be addressed. The overall status at discharge, indication of the patient's status. And lastly is disposition. As I begin this tutorial, this patient will be going to a tertiary center, a hospital, and I will indicate that here. I then will need to file the actual discharge order, clicking on Edit, choosing only one field here, which is required, discharge to. and you will see in this situation the patient is going to a tertiary center. Don't need to fill out any of these other fields, which is quite nice. By clicking on Next, I submit, enter my PIN, and I have completed all of the required fields for meaningful use, med reconciliation, follow-up instructions, and disposition. Now, patients that are going to tertiary centers, skilled nursing facilities, or rehabs, or that are receiving home health care with visiting nurse will require a page 1. That's this next tab. Going to the page 1, typically the only fields really that should be filled out by the provider are involving the physician orders, which is this first section. The clinic is not necessary to indicate, but treatments and frequencies, this third line, is usually very important. And this is where you would want to indicate any tests, blood work, or follow-ups or specific instructions to nursing who will be following this patient, whether at a rehab facility or a visiting nurse, will be referring to these essentially as doctor's orders. So by opening this, this is free text. In this scenario, let's say that the patient has to have a PICC line removed after completion of antibiotics. So here I might indicate to the facility or whoever's caring for this patient, removing the PICC line after last dose. I might also ask that they draw some labs. Again, any other specific instructions, labs, etc. that you may want to indicate to this patient. Certainly dressing changes, staple removal, etc. Having done that, physical therapy, these are fields that can be addressed, certainly for weight-bearing status and activity. Home health aids, if the patient is going home, nursing, or other therapies that may be required. And then certification. Yes, and required skilled nursing, again, depending on the scenario. The last tab is the quality tab. This again is a required field for compliance and regulation, and this is for meaningful use as well. Obviously, patients come in with a variety of clinical diagnoses and treatments that have nothing to do with stroke, or have nothing to do with VTE. However, it is imperative that these be reviewed, and you'll see that these are required by the stars next to them. Does the patient have a confirmed VTE? The answer is no. Do they need overlap? Obviously no. And did the reason for they did not receive it? It was not indicated on this patient. Also for stroke, the patient did not come in with stroke, so this is quite easy to deal with. I have now completed my discharge hospital course, addressed the ICD-10 codes and discharge diagnoses. I've done my plan, which has outlined all of the necessary requirements for meaningful use, med reconciliation, follow-up, discharge instructions, transition of care document, and for patients going home with services or to a tertiary or extended care facility, a page 1, which was required. Lastly, I've done my quality tab, and at this point I have now successfully completed my discharge summary. At this point, I would say View Save. A cosigner is required for residents and physician assistants. At this point, I enter my PIN, and I have completed my discharge summary. Now, prescriptions were printed out earlier in the discharge process routine, as was demonstrated, but the transition of care and the page 1 do need to be printed out and signed by the provider. In order to do this, the best way to do this is, first of all, going back to the patient list. You'll find the patient we just finished, And in order to print, first of all, the page 1, which is required for transfer to the tertiary or extended care facility, you will need to check a box on this list. Well, you'll notice it's not intuitive, but for this patient, by scrolling over to your right, you'll see this box over here to the far right. When I click that, I now have access to reports. Down here on the footer button, you'll see this report button. By clicking that, I need to switch to list only, no. One line is already defaulted in, and it's the patient care referral form. That is the same thing as the page 1. The first time you do this, this will not be listed here. As I filled out before, it defaulted in as this was the last thing that I chose. If it's not noted, then you simply can look it up from the list and choose the patient care referral form. This is the page 1. By clicking OK, this will then bring all the information you filled out, including the med list that you have reconciled. That will be all in one standard report that will accompany the patient to their tertiary care center, rehab facility, or will go to visiting nurse that is caring for them at home. And this is what the process, or at least what the output would look like. Patient's medication list, instructions, and the certification. Having printed that out and signed it, placing it on the chart, this will be the information that's needed by the social work case management. I hope this process and reviewing it has been helpful. Take the opportunity to go back over the document once again. Granted, it is a somewhat convoluted process. There are a lot of requirements, but this is the expectation organizationally for safety, for compliance, and for meeting meaningful use. If you have any questions, please feel free to reach out to the medical staff educator.